Okay. Welcome, everybody. Glad to see you again. I hope everybody had a good, healthy, and productive week. Here we are, Sunday night, our fireside chat with Glenn Grossman, our epidemiologist extraordinaire. Try to spell all that. Me. As we know, Glenn Grossman is an epidemiologist with over 20 years of experience. While pursuing his doctorate in epidemiology at UNC Chapel Hill, Glenn served as an epidemiologist on staff at the UNC Infectious Disease Clinic for 2 years, and he taught epidemiology and advanced analytics at Duke Medical School and at UNC. He has been involved in epidemiology projects with Medicare, Medicaid, Veterans Health Administration, Military Health Service, the CDC, and other programs inside the United States and abroad. He is currently Senior Director of Outcomes Research and Epidemiology at Novartis, but all views expressed today are his own. Okay, Glenn, how are we doing? Take us around New Jersey, around the country, and around the world.
Great. Yeah, Rebecca. I figure we'll just spend a little bit of time talking about the epidemic this week. And there's so many questions about the vaccine and the treatments that have come on that maybe we can spend some more time talking about that today. But to start, let me just share my screen. All right, so here is where we are. So as you can see, this is the United States. We have been testing a lot better over the last, I guess, since it's been growing around the country tremendously, which is really good news. Unfortunately, you can see when you compare the first outbreak in March, April, when diagnosis rates were poor, to the second surge versus the third surge, the diagnosis rates are slightly better now than they were during the second surge, but they were already pretty good by the time the second surge was happening. And so the order of magnitude of the current infection rate is astonishing. You see that we're almost at the point of almost 200,000 new cases diagnosed per day. And we'll probably hit that this week. And when you look at that, where we were at the peak back in July of around 65,000 on average over a 6-week period. So I guess our average here is around 167,000. And it's just rising tremendously. Here, what's even more critical is when you look at the hospitalization rate. The second surge hit the same peak as the first surge, but across more hospitals. And so the currently hospitalized rate includes the same people over multiple days, because as long as they're in the hospital, they'd be captured under this curve. And you can see that this is just an exponential growth rate that we're looking at, and there's no end in sight for the hospitalization rate. In fact, one article that we're looking at is that at the rate we're going, this is from Bloomberg, 1 in 5 US hospitals face staffing crisis within 1 week. So we're really not in great shape right now, and things are only going to get worse. One thing I'll point out here, let me see how quickly I can find this slide. All right, so, where did it go? Oh, here it is. So when you look at the, let me make this bigger. So when you overlay the curves of the cases with deaths, what you find is that on average since July, it's been pretty consistently a delay of around 18 days between the case rate increase and the fatalities increase, the deaths increasing. And so you can see when you overlay the curves, it's really a tight fitting curve. So we can anticipate that we have roughly an 18-day lag that we're looking at. And so what that means is when you move the curves to 18 days, so when you move the death curve 18 days into ahead so that they overlap, then that means when you look at the number of new cases that were just diagnosed, it means that we're going to be hitting probably 3,000 deaths per day within 18 days. And so this is astonishing. So when we look back at what we were just looking at, the peak that we had in the first back in March and April was slightly over 2,000 deaths per day on average when you look over a weekly average. Obviously, there were a couple of days where you hit some really high numbers, but what's most important is to look at the weekly, look at the average daily death rate when you average it over a week, because there's a lot of noise in the data. And so at the rate that we're going, we're on this exponential curve. One other thing I wanted to point out to you was this shape of this curve. So one thing that I thought that would be interesting was to look at how steep the slopes were. So when you look down here, I put a blue line there in terms of the slope at this point in the curve, early on, and when we're looking at like mid-March, end of March. And when you, here's that same blue bar, and you see that the curves are steeper than they were now when you look at the green. In fact, the green here was when we started going at a more accelerated rate back in early April or so. And that's essentially where we are now. So the shape of the curve that we're looking at was essentially back where we were at the end of March, early April, where we're having this exponential growth, no end in sight. We would need radical shutdowns in a bunch of states right now. And then even then, based on what we discussed, it's an 18-day lag in terms of the impact on the transmission to cases to deaths. So this peak is going to just keep on rising for a while. When you compare the second surge deaths, this was the orange one that I have here, just so you can see. The orange one is what our death rate looked like back in October, end of October and early November. But it's just over the last week or so, last couple of weeks, just started to dramatically exponentially rise. And so things are really in a crisis moment right now. If we go back over here, and so you can see like over the past week, we did hit a day and a couple of days where we were approaching 2,000 deaths per day. And so like this day was essentially 2,000 deaths per day. Again, it's important to look at the average because on like weekends, we don't capture the death rate quite as much, but you see that the lines are very quickly approaching back where we were March and April. The one key difference being that in March and April, it was mostly the Northeast, a couple of states that were hit. But now when you look at this is what we're looking at is the single day record case for each state. You can see over the last week or two that most of the states in the country have hit their high in the last week or two and only getting higher since then. A bunch of states have not yet hit what their high was, but we're slowly getting there. All right, let me go to the how we're looking worldwide. So right now the key epidemics, Asia's been good in terms of their response. Typically, you see when you compare them relative to others, Asia's been doing really well. Africa's been doing amazingly well, largely because of demographics, but also because of really strong intervention from some of the governments there, primarily Asia. For Africa, the demographics are really there's a lot less old people in Africa, a lot less very sick people with long-term comorbidities that put them at high risk. And so that's one of the reasons that Africa is doing well. But when you look at this, let me just look at Europe as a whole. All right, here's Europe. All right, so you can see that some countries were like in Europe, specific countries like France and United Kingdom were not doing very well, but then they shut down and they dramatically were able to reduce their curve very quickly. Whereas in contrast, the United States is just on this upward curve, and there's not anything that's really going to stop us anytime soon. And so we'll talk about that. Beck, would you like me to, or Rebecca, would you like me to go and talk about the projections and skip to some of the questions on the projections in the United States?
I think that's a good idea.
All right, so we'll transition to that. All right, so let's look at the projections. So last week we talked about the forecasts by IHME, the Institute for Health Metrics and Evaluation. They just redid their forecast again a few days ago, and you'll notice that there are a lot more states that are now expected to need to go under a lockdown. So for instance, New York and New Jersey were expected to not need to go under lockdown before March under their previous forecast. But now it's expected that New Jersey will go and need to go under lockdown by December at some point, and New York probably by January. And there's a bunch more states. You see all these oranges now. Quite a lot more of this of the country is anticipated to need to go under lockdown before March. So things are accelerating much more rapidly than we even thought a week ago. So that's one thing. When we compare what the model was based on, so the model, the estimate of which states would need to go under lockdown was based on this assumption that once the daily death rate passes 8 million deaths, or rather 8 per million deaths, that would be enough that the states would need to go under lockdown, and that any rational government at any of these states, when they hit that level, they would just shut down because they cared about their citizenry and they didn't want them to die. So I thought it would be interesting to go back and look at what states are currently at or near the 8 deaths per million daily deaths as a metric. And you see that when you look at South Dakota, for instance, they're approaching 30 already. They're approaching not too far from where the peak was in New Jersey and New York back in March and April. And they're not even shutting down anywhere what we did back in March or April for New Jersey or New York. So things are the whole forecast that I'm about to show you in terms of what we can expect is based on them shutting down. If they don't shut down, then it's just going to be churning out the virus, and a lot more people are going to die. So these are all the states that have now exceeded the this threshold that IHME is using for when they expect the states to shut down. So all of these states have now exceeded that threshold. When we look from the New York Times, this is the best dashboard that I found on what the restrictions and mandates currently are. So currently, why don't I start with the mask orders? So you'll notice that there are a lot of states that still do not have mask orders. It's astonishing. Where they see what's going on in the country? They haven't even done the most basic mandate of requiring people to wear masks when they're out in public in a bunch of these states. And this is just astonishing. Some of these states include South Dakota, which you just saw has the highest death rate in the country right now in terms of the number of people dying from COVID-19. It's just astonishing. And so here's where the shutdowns are predicted this month. And it's already November 22nd, so there's only another week left in this month. And so this is how many states are expected to shut down if they were using this threshold. In terms of businesses that are shut down, so not as many businesses have mandates as the mask that we just saw, but there are a few. So this is the new November 19th forecast in terms of who's projected to shut down. And one thing that's striking is that some of the states that wouldn't have been expected to shut down, so for instance, I'm looking up here at Washington, I'm looking at California, because they were doing poorly back in March and April, they've already taken it on themselves to already put way more restrictions on early on to prevent it from getting anywhere near as bad as it was back then. And so these already have restrictions on businesses where many are closed. New Mexico has severe restrictions, and a few of these other states that you see here. In addition, there's mixed closures or curfews that are in place in some of these places. However, when you look at actual shutdowns, there are not many with stay-at-home orders. Again, California was not expected to need to shut down, and yet they shut down here. And the reason is that they are really concerned about their citizenry, and they are trying to prevent this spread. And it's not just fatality that's the worry here; it's the long-term consequences of the disease. I'll just spend a couple more minutes here, and then we can move on to questions. So here's the difference between the November 12th projections and November 19th. You'll notice that previously we were not expecting to hit 2,000 deaths per day until January in the previous base case projections. And now we're expecting that we're going to hit 2,000 per day by early December, which is clearly what we're on track to do. if not before that. And we might easily see another revision from IHME in another week or two that even makes their forecast go even higher than what we're seeing here. In terms of the totals that we're looking at, previously we were looking at by February reaching over 400,000, so approaching 500,000 or 450,000 by March. Now we're getting closer to 500,000 by March. So we're on a bad curve. We're on a bad slope. We need to get off the slope, and that's all policies. There's no other way to do it except from public mandates and restrictions from government. All right, I think that's all I was going to say here. Oh, one other thing that I was just going to mention here is this question. So this question had come up about testing versus cases. So we had seen over here, I'll just come back for 1 second. It looks just on the surface, when you look, you can see that there's been a very dramatic increase in testing and a very dramatic increase in cases. Couldn't it simply be that it's just an illusion, that the cases aren't really rising as quick as we thought because the tests are rising so fast and it just seems like the cases are rising? Well, in fact, when you look at this, I just did a quick analysis. When you look at this, 30% of the cases are occurring in states that have only 13% of the tests. And vice versa, when you look at the highest testing states, 34% of all the tests conducted in the United States are responsible for only 13% of the cases. The key takeaway from this slide is that the surge in testing is not occurring in the same states as the surge in cases. And so that means that even though at the national level, when you look at this and you see, oh, look, there's a rapid rise in tests and there's a rapid rise in cases, these are not happening in the same states for the most part. And so it's actually not the case that the tests are actually responsible for visualizing more cases. All right, Rebecca, back to you.
Thank you for breaking that apart. Like us, Glenn, I think that's really very interesting and a question that's come up a bunch of times. Why is it when those graphs look so similar, can't we deduce that one is reflecting the other? And so that was a really interesting way of breaking it apart. Thank you for that. So we have a lot of questions that have come in this week. It has been a busy week on the COVID front and lots to talk about with vaccines. Lots of questions have come in. What do we know about the myriad of vaccines that appear to be on the horizon?
Okay, great. That's a broad question, and I can just jump right in.
Feel free to simplify.
Feel free to simplify. That was already a pretty simple question. I was going to expand upon it. All right, so let's jump in here. All right, so first we had heard about Pfizer's vaccine. Now I think we've heard about Moderna's. They have similar results. This is not that. This is something else. All right, let's look about. All right, so basically, let's take a big step back here. All right, let's talk about vaccines. I like talking about this. All right, so vaccines. What are we talking about here? Let me show this. Let me bring this to the top. All right, so basically, when you look at the coronavirus structure, there are lots of different kinds of proteins that are on the surface, like they're sometimes called glycoproteins because they also have sugar involved in them. Sugar is involved, but these glycoproteins. There's 5 or 6 main ones that we're looking at. So the spike protein we've all heard about, and this is what we've been talking so much about, because antibodies that can attack the spike protein, some of them are neutralizing because it's the spike protein that is what binds with the ACE2 receptor, and it's how the coronavirus gets into most of the cells. Now, again, we've also talked previously that there are the FC receptors, and so that's another type of receptor that the coronavirus can spread to within the immune system. But for the most part, it's these S proteins that the coronavirus is getting into the cells and replicating with the ACE2 receptor. But there's other proteins on the surface. There's the hematogluten esterase protein, or it's an esterase. There's a membrane protein. There's a nucleocapsid, N protein. There's the envelope, E. Each of these can have antibodies that form on it. And so these are all different points that antibodies can learn to attack. And the reason is, let me go back to the basic biology of vaccines. So basically, a vaccine, a virus, when it enters the cell and starts replicating, it eventually triggers an immune response. We've talked about this a little bit briefly before, but basically what's happening is by triggering the immune response, there are special cells called these antigen presenting cells. And each one of these things that I just showed you, each one of these proteins is an antigen. An antigen is anything that an antibody or the immune system might respond to is an antigen. And so basically it's the antigen presenting cells that then rip open the cell and show all of the different possible antigens. So then the antibodies and the T cells, two different mechanisms, the B cells form these antibodies and the cytotoxic T cells come in and kill the cells that have virus replicating in it. So one more time, the antibodies attack the virus itself, whereas the T cells attack the cells that are infected with the virus. All right. So, but the key thing here is that when you have a natural infection, the antigens are very diverse. So people who have a natural infection are infected with all of these different, create antibodies and responses to all of these different proteins and antigens. In fact, this is a really interesting shot. All right, so basically what we have here is a screenshot. This is what it is from scanning electronic microscope, and it's scanning electron microscope, and it's been colorized to show some of the different portions of it. But the two things I want to draw your attention to here are the S protein, so again, the spikes, and the N protein, which is inside the virus. It's not a cell, it's inside the virus. And so the N protein wouldn't be exposed until after the virus has been ripped open by the immune system. And so antibodies that respond to the N protein are ineffective because if they see a virus circulating around, the N protein is hidden. And also, when you really zoom in even closer to the S protein, you see that the S protein is somewhat complex. There's different portions sticking out, there's different parts, some are bigger, some are smaller. And so different vaccines are focused on different parts of the S protein. And so vaccines may be better or worse or more efficacious or have different side effects depending on where on the S protein they are focused on. And one thing that we're not doing, and so pretty much all the vaccines, as far as I can tell, are focused on the S protein because then they have this benefit of also being neutralizing. And again, the neutralizing part is that in addition to, so normally what an antibody does is it flags the virus for the immune system to come and destroy. And so it's just a flag. Whereas if you put the flag on the S protein itself, then it physically is a barrier that prevents it from binding with the ACE2 receptor. And so we call it a neutralizing antibody or a sterilizing antibody. And so if it can't replicate because of that. All right, so now we've talked about the basics there. So both in terms of the vaccines and the monoclonal antibodies and polyclonal antibodies that we'll talk about, they are both responding to different parts of the S protein. So for instance, in the Lilly monoclonal antibody that we talked about last week, it's a single antibody that responds to the S protein, to a portion of the S protein, and it's just a massive amount of pure neutralizing antibody that's just infused in. The second thing is Regeneron's new emergency use authorization that we'll talk about today. Theirs is what's called a polyclonal antibody because it's actually two monoclonal antibodies. What Regeneron realized was that what if there's a mutation over the next couple of months? They want to future-proof their treatment. And so by doing that, they figured if they made an antibody to one portion and then an antibody to a completely different portion, then even if there's a mutation that makes one portion less effective, then at least the other portion will still be effective and knock it out. So they're expecting that theirs this 1-2 punch will be more effective and more future-proofed. All right, let's go back into the vaccines. There were some specific questions that we had. So let me go back into some of these things. Where was this? All right. So we know more information now than we did last week. Not a lot more, but a little bit, but a fair amount more. All right. First, so now we've seen results on a bunch more people. As of now, there were 170 confirmed cases of COVID-19 in the Pfizer vaccines. 162 of those were in the placebo group, and only 8 were in the vaccine group. Even better are these two things that I'll show here. One is that this was consistent across age, gender, race, and ethnicity. These were specific questions that we had last week, and now they've given us a preliminary answer. And people over the age of 65 as well still are expected to have a 95% effectiveness, which is really great news. The safety data demonstrates that there were very weak safety issues. There's basically 2 or 3 types of safety issues that I'd be concerned about with the vaccine. So again, what we're talking about here, we haven't talked about this. Let me jump in for a second. So essentially, so this is a messenger RNA vaccine, which is different than other types of vaccines that you'll have thought about previously. It's a totally new technology for antibodies. We have used monoclonal antibodies for a lot of therapeutic areas. We've been using it for many years now. We understand how the technology works. But this is the first time that it's been used to create vaccines. And even though it is not monoclonal antibodies, I just jumped. That this is the messenger RNA used for vaccines. All right. So basically, what happens is normally again, if you look here at the secreted protein, this is another way of talking about this is the antigen. And so this is the S protein that they're creating the vaccine for. Normally, what you would do is, let me come up here. Normally, you would have a few different ways of doing it. You might have, in the old days, weakened virus or inactivated virus, where it's essentially the whole virion with all of its parts and stuff still there for the most part, but it's either weakened or totally inactivated. But all the gunk, the N protein that we would have talked about would have still been in there. That is not what we're looking at here. Other vectors could have been replicating virus where you take the key antigen and put it on a different type of virus where the virus doesn't cause any problems, and it just the S protein is almost just going along for the ride just to create the antibodies. So you create antibodies for it. What's different here is that we are not using this vaccine. They are not delivering to us the protein. They're not delivering to us this antigen or anything that's like a virus at all. What they're giving us is a snippet of RNA. The RNA goes into our cells and then uses our own cellular machinery to create the antigens, to create the S protein. And so then essentially what you have is here, instead of having a whole big virus floating around, all you have is the little snippet of whatever the S antigen is that this S protein is that's going around. And so it's just like millions and millions of copies of these tiny, tiny little snippets that are just floating around. So the only type of safety issues that I would be worried about are I guess 3 types. One are injection types of reactions, or let's say 4 types. One are injection types of reactions. And in this case, we didn't seem to find any, which is good. And that's what would be expected. 2 would be, let me come back over here. What if there's something about the S protein? Like what if the S protein is somehow interacting with the ACE2 receptor? And so they looked at that. No, there was no safety issue there. That's great news. Third could be, well, what if you're producing something and the RNA has some sort of side effect with the vaccine? And so even regardless of whether they're infected with SARS-CoV-2, just the process using this machinery, what if there are safety effects there that we need to worry about? And based on the early results, there's no safety concern there. So these 3 things, great news. There's no big safety effect. In fact, the only safety issues that we found are, where was I? This was not it. Where was I? All right, it was back here. There were only a couple big, somewhat meaningful safety issues. One was, and they were didn't occur very frequently. So fatigue, so getting tired and exhausted was occurred in around 4% of people who received the vaccine, and headache occurred in 2%. So generally, the vaccines were extremely well tolerated, and there were no serious safety concerns observed. The other thing that I've been talking about previously are these things called these antibody dependent enhancements. And so going back again to the S versus the N, so now the N protein, let me see if I can pull this out pretty quickly. The N protein has been found to cause problems. And the N protein, the types of problems that the N protein causes are, and I won't be able to find this real quick. I had a good snippet. The N protein has been found for vaccines for SARS-CoV-1 to be part of the problem of causing enhanced immune responses. So if there were going to be an antibody-dependent enhancement, this really big problem that I've been talking about, it would probably occur only with the N protein. So what that means is, unfortunately, people who have previously been infected are very likely to have antibodies to the N protein. So that means that getting infected a second time could actually increase their risk of getting more severe disease. And we actually have seen this in some people already. And so I've mentioned it in previous weeks. We can go through it again at another time, but this is a cause for follow-up. And so we don't know how widespread it is. Typically, like I said, people who produce antibodies produce a diverse number of different kinds of antibodies, not just N protein, but S and all the different kinds. But the N protein antibodies could be these malicious ones. But because the vaccine that's generated here is only the S protein, very, very precise, then that means that with all the concern of these antibody-dependent enhancements, that's this one, the underlying theoretical understanding of what could cause these antibody-dependent enhancements, it lacks an empirical basis using the S protein. So this is also really, really great news. Based on all of this, I am extremely optimistic about these vaccines now. Even though the sample sizes are quite small, all of this early data is extremely great. I mean, it's hard to say. I mean, you can't say anything less, anything more negative than that. If anything, it's way better than great. It's amazing, to the point that now we need to look at how much is actually going to be available. So Moderna is hoping that so they're the two big messenger RNA emergency use authorizations that have either happened or are about to happen. Moderna is saying that they'll have 500 million to 1 billion doses by 2021, but they're going to have a problem ramping up past that. Moderna was given some of the Operation Warp Speed money by the U.S. federal government. The Pfizer vaccine was not. In contrast, Pfizer, they're expecting that they will have, oh no, this is not that they'll have roughly the same amount. I think this was it over here. Here it is. They're expecting that they'll have roughly the same amount, 50 million vaccines by the end of 2020 and 1.3 billion doses by the end of 2021. Because they're seeing essentially identical signal between those who are at high risk versus those who are not at high risk, probably what's going to happen is the vaccine is first going to be given out to people on the front line who are treating the virus around the country. So people who are in the hospitals, physicians, nurses, etc. Then it's going to be given to people at high risk, people over the age of 65, people who are at high risk because of comorbidities and whatnot. It does require 2 doses. I think both of these require 2 doses, if I remember. Luckily, the Moderna vaccine does not have to be frozen at the same level. The Moderna vaccine has very different logistical requirements. if you recall, the Pfizer vaccine needed to be stored at negative 100 degrees Fahrenheit, essentially, whereas the Moderna vaccine doesn't need to be anywhere near as cold. And so I don't know if it's just regular freezers that will work, but it doesn't require anything near as cold for it to work. I think regular freezers might be sufficient for that vaccine. And AstraZeneca's and Oxford University, that's probably next in line to show results. Johnson & Johnson is also possible to come soon. These don't even need to be frozen at all. Those just need to be refrigerated. So between all of these different options, and because they're all focused on the S protein, very, very likely we're going to see very similar results across all the different vaccines that are coming. Again, the big difference here is just in how the S antigen gets into our bodies. And so because it's just different ways that we're getting the S protein, but all that matters for our antibody and our T cells to have this response is to see the S protein in there. So because of this, most of these vaccines should work now. But assuming that the S protein that they're focused on, that the part of the S protein is very similar. So I'm very, very optimistic now about the vaccine strategy in general. Also, I'm even at least as enthusiastic about these monoclonal antibodies. Rebecca, is this enough about vaccines? Did I answer the?
Yeah. So you spoke about the monoclonal antibodies a bit. Do you want to dig in a little bit deeper on the monoclonal antibodies and treatments that we've seen lately that are really starting to show some good results?
Yes. So again, the difference between the monoclonal antibodies is they bypass the whole vaccine. The way a vaccine works essentially is it's a big Rube Goldberg device. You put the antigen out there, the protein, and it bumps around the body, and the body's immune system responds, and all this stuff is going on. In contrast, the monoclonal antibodies are just pure antibodies and neutralizing antibodies. And you just inject a massive dose in, and you don't even need the Rube Goldberg device. You immediately have a response. The problem is, and this is what we talked about last week, let me come back to it for a second. The problem is this, is that it's potentially a miracle cure. It's been demonstrated already with the emergency use authorization, just in the preliminary results, to reduce mortality by 70%. And the thinking is that the earlier you get the dose, the more effective it is. To the point that if you wait until your symptoms are too severe that you need to go to the hospital, it's too late and it won't work. And so depending on where you are on the spectrum, if you get it like a day before you would have developed severe symptoms, then it's maybe works a tiny bit, but not very much. Whereas if you get it right after, like hours after you get exposed or get the first symptoms, then it's dramatically effective. So Bamlanivimab was the first one that we saw that was given emergency use authorization last week. Now Regeneron's has been given emergency use authorization. Regeneron's, like I mentioned, is a little bit different because this is a polyclonal antibody. And so theirs is called, I'm not going to be able to pronounce this, casirivimab.
Okay, because I think most of us were really impressed with by the way that you said Bamlanivimab. I got it wrong.
That way. and so these are luckily these sound the way that you spell it. So casirivimab and imdevimab. So these are the the polyclonal antibodies. So basically, when you get a dose of this, you're getting both of these, and so that's why it's called polyclonal antibody. It's the same exact constraint as we had before, and so what that means is that the people who need to get it, they're the high risk people. Let me go through that list one more time. We talked about this last week, but it's good to review. So the people who are at high risk are people who are obese with a BMI greater than or equal to 35. If you have chronic kidney disease of any age, diabetes at any age, immunosuppressive disease of any kind, currently receiving immunosuppressive treatment, so oncology for different types of therapeutic modalities. If you're over the age of 65, even if you have no other comorbidities, that's sufficient to get you on this drug if you qualify, or if you meet any of these other criteria. The first one is So among people who are over the age of 55, you need one of these other things. You need to either have diagnosed cardiovascular disease or hypertension or chronic obstructive pulmonary disease or other chronic respiratory disease. The other option is if there's kids who are age 12 to 17, then they qualify if they have a BMI greater than or equal to the 85th percentile for their age and gender, if they have sickle cell disease, congenital or acquired heart disease, neurodevelopmental disorders, a medical related technological dependence, or asthma or other chronic respiratory disease that requires daily medication for control. People who meet any of these criteria, if again, the key thing here is they need to get diagnosed ASAP. They need a positive SARS-CoV-2 test. If they wait until they have symptoms and the symptoms get too bad, then they're not going to have access to the drug. And as we know, it's getting harder to get access to a test because so many people are trying to get tested now. So you need to urgently get a test. If you meet any of these criteria that we just discussed, both of the drugs have the same high risk criteria in terms of the people who would be eligible to receive it. These are life-saving drugs. Again, the Regeneron one is the identical one, a clone of what Trump received. So he would have received the best available in the world. And this is what he received. This will save your life almost certainly based on the emergency use authorization. I mean, there's still more evidence that needs to accumulate, but to the best of our knowledge so far, this is a life-saving therapy.
Glenn, do you want to remind folks to take down the 24-hour support line for further questions?
So I put the 24-hour support line here for Bamlanivimab, but not for Regeneron. But you can look at Regeneron's website for theirs. So this one is 1-855-545-5921. The other one is Regeneron. The big issue is going to be, so again, let me put out the constraints, because I've said who can get on it, who can't. Once a person is hospitalized for COVID-19, it's too late. Not only does the drug not work, it probably makes things worse. So people who, once they're hospitalized, cannot take this drug, it's too late. People who require oxygen therapy. So for instance, we've talked earlier in the year about the oxygen measuring devices that we've talked about. Those, they don't work for this. If you do use the oxygen devices and your oxygen is too low, such that you'd require oxygen, it's too late. If you require, so it's basically oxygen, it's hospitalization or requiring oxygen. What this means is that if you think you might have been exposed at the very first sign of a symptom, and what are the symptoms again we're looking at? Fever, newer increased cough, shortness of breath, chills, muscle pain, all the things we've talked about, loss of taste or smell, sore throat, diarrhea, vomiting, fatigue, headache, nasal congestion or runny nose, or nausea. If you get any of these that are new, that should be a trigger for you to go and get a SARS-CoV-2 test ASAP. I'm talking about within hours or a day. Do not hesitate on this. And one other thing that we talked about last week is that just having any of these symptoms doesn't mean you're likely to have SARS-CoV-2. In fact, there's a lot of reasons someone might have a cough or a fever or fatigue that are unrelated to SARS-CoV-2. And so we've talked about the positive predictive value of tests before. It turns out that if you have a cough, you might only have a 20-25% chance of having SARS-CoV-2. So it doesn't necessarily mean that you have SARS-CoV-2, but it should probably be a trigger for you, because now we know we have a cure. If you're in a high-risk group, that you should be using this as a trigger to immediately get tested and look around for the test. That's one of the limiting factors here, finding a test where you can get the results, not within a week, but within a day or two maximum. Maybe sooner if possible, if you could find some of these antigen tests. The problem is that some of the antigen tests give a lot of false negatives in addition to the false positives. And you really need to, if you are positive, have a true positive, you really need to identify a test that has enough sensitivity that it will tell you, that give you a positive result if you are positive. All right, the next big constraint is the amount of doses available. So let me go back down to Regeneron again. Neither of these are going to have a lot of doses available. This was not that. This is Regeneron. So here is the doses. All right, so Regeneron has said it will have enough of the drug for only 80,000 people by the end of November, enough for and enough for 200,000 patients by the first week of January, and 300,000 by the end of January. So they're ramping up really fast. Although on their website, it conflicted a little, and I don't know exactly why. But on Regeneron's website, I just got this today. It said initially they expect to have treatment doses for approximately 300,000 people in total delivered between the end of November. Oh, so it's the same, and end of January 2021. So 300,000 doses is not a lot. We know that there are many, many, many millions of people, tens of millions of people in the United States that meet the criteria that we were talking about. So over age 65, with all the different possible comorbidities that would be a trigger. The thing is, almost none of them will realize the importance of getting a test ASAP, or a lot of them are probably not even aware that this drug exists. So that means if they're getting tested, it's probably just a coincidence if they were to find out about this. Where, in contrast, if you're highly motivated and you know that you're at high risk and you go and do everything you can to get a test and to get the drug, there is a reasonable possibility that you'll be able to find a dose, because a lot of people just don't know about it. So I think that even though it's not very common, there's not a ton of it, there's a pretty good chance that you'll be able to get on it if you are motivated and you have people helping you to find test results where you can get results quickly and identify the product. All right, any more questions about this stuff?
Fascinating, really, really helpful, and really, really good information, Glenn, to have for people have at their fingertips. God forbid should they need it. Okay, so last week we ended our conversation talking about Thanksgiving and traveling, people planning on getting together for the holidays, and you gave a bit of information about that folks should get tested last week if they planned on being together this week, and really try to quarantine and sort of isolate before traveling. Can you tell us more about, now that we're in the week or approaching the week of Thanksgiving here, what folks should know?
Yeah, definitely a great question. So it's not being tested last week. What I was mentioning last week was that if people were planning on getting together, they should quarantine. They should have quarantined last week.
That is what you said. I got that.
So if you're under quarantine for 14 days, you really don't need to get a test at all, because the test is probably going to be either a false positive or a false negative, and the results are so far in advance that even if you get a negative test, you could still be positive. The 14 days is probably sufficient for most people that the test wouldn't actually do anything for you. But now we are only a few days away from Thanksgiving. So now quarantine, it's too late. It won't work. It will work if you decide that you want to get together with family or friends for Christmas or the holidays or New Year's Eve or Hanukkah or any of the other holidays. Then you can still think about quarantining 14 days in advance of the holiday would be best. If you have not quarantined, or if you have, these are things that you should be considering if you attend. One, anyone with any possible COVID-19 symptoms during the period must not attend. If you have any of the symptoms we just discussed a little earlier, fever or cough or any of the things that we discussed, do not attend the Thanksgiving holiday. Even if you have it a few days in advance and you feel better the day or two before the Thanksgiving holiday, do not attend. You could still be contagious, and so do not attend. If you go to the event, anyone who's hosting an event, there should be an exceptional amount of outdoor air ventilating throughout the event. If at all possible, have the event outdoors where you can physically distance, wear masks, and if you are eating, people are going to take off their masks. So you need to be as far away as possible. If I remind you, the 6 feet idea was originally back in March, April, was based on this idea that the virus would be spreading through these, like essentially through spit, through large uh, particulates of the virus. But now we know that it spreads through the air. So the 6 feet rule no longer applies. Someone could be asymptomatic with the virus and then be sitting in a room, and 20 feet away, someone could be sitting over there with a mask. And if they're in the same room for 3 or 4 hours, the circulation's not great, and the person's talking or talking loudly or yelling or singing, the person 20 feet away could get infected. So the rules are different now. We know the 6 feet thing doesn't really matter as much. That's why we have to be more concerned. Here are the other things I would look at. One, wear masks when you're not eating. Two, physically distance yourself. Even though none of these things are perfect, physically distancing yourself is better than not physically distancing yourself. If at all possible, lower the volume of background noise to reduce shouting or singing. We know, and I'll get into this into a slide in a second, that raising your voice, like at a bar, or raising your voice, actually contributes to these super spreader events and contributes to more of the aerosols going out into the air in a room. So the quieter the room is, the less background noise, the lower the speaking voice, the less likely that you're going to have the aerosol spread. And then the other thing is limit the time of the event. In a normal year for a holiday, if you might have an event that lasts 4 or 5 more hours, this year I would try to limit it to 2 or less hours, because the length of time you're exposed makes a difference. If someone's sick and you're exposed for 4 hours, you are at much less risk if you're only exposed for an hour or 2 hours, even if you're doing all of the other precautions. Let me talk about a couple of other things. So when we're talking about super spreading events, which is essentially what we're at risk of having if we have a holiday party, even if it's not a lot of people, even if you have 10 people that are there, it's a super spreader event. So these are the key risk factors for super spreading events. If it's a closed space, so if you're inside and it's a closed space, that's a risk factor. So have it outside if possible. If it's not possible, then what I would do is blast the heat inside if it's really cold outside, and open all the windows and doors so you have tons of fresh air coming in, so you have constant air circulation. But then it's going to get presumably somewhat cold in some of the northern states this time of year. So then blast the heat, put on the fireplace, have people wear jackets even though they're inside. That will make a huge difference for that part. The less enclosed, the better. Close contact. So the further people stand away from each other, the better. If you have contact that's too close, it facilitates a super spreader event. Crowds. The more people that are there, the more likely it'll be a super spreader event. Whereas if you have smaller number of people in the same space, then that is less of a super spreader. Time together makes a big difference. I mentioned that. Unmasked makes a big difference. And then this other thing that I just mentioned that a lot of people don't talk about, these 3 things promote environments that have these 3 things promote super spreader events. So if there's an environment with a lot of shouting, singing, or heavy breathing, like in a gym or something like that, then these are the types of things that promote super spreader events. So for holidays, try to restrict that.
Glenn, Sandy has a question about fans. Sandy, if you could unmute, please.
Okay, Glenn, thank you. That was very helpful. And as concerned as I was in the beginning and protecting ourselves, now it's even worse. So when you talk about fans, we have we're outdoors, we have it's warm, we have a ceiling fan, we have a floor fan, but in a way, won't that increase the circulation of those particulates? If we're already separated at least 10 feet, let's say, wouldn't that, and somebody sneezes while they're eating, their mask is off, would that spread it now to the other side of the room?
Well, so I believe you're talking about essentially an enclosed patio type of situation,
Yes,
right?
yes.
And so it's outdoors, but it's kind of screened off.
Mm-hmm.
So what you would need to do is try
Well,
to make
okay.
as much air exchange as possible. So the fans can your fans be at a maximum speed where you actually feel like a breeze when you're sitting out there? Because that would make a big difference. If you can get the air circulating, then if it pushes the air away, so if someone sneezes, then it would very quickly leave that patio area, then that would make an enormous difference.
So it
The-
should be from the inside of the house out. away-
exactly.
Yeah. Okay.
Inside, it should be pushing out. And the next thing is, but the one thing precaution that which is what I just mentioned, if the fans are too loud and people need to shout to talk to each other and they stand closer to talk to each other, then that's not going to help. So
Okay.
it needs to be somewhat, it has to be a lot of air circulation, but it needs to be at a quiet enough amounts that people are not raising their voices or getting too close.
Those are wonderful points. One other question, Glenn, what about serving utensils? And should there be one designated server so that people aren't touching?
That's a really good point.
But that's not airborne, so do we still need to worry about that?
Yeah, it's a really good point. So what we found, so that what you're talking about are essentially these things called fomites, which is when you touch a utensil or something, someone else picks it up and then you get contaminated there. Even though it's airborne, someone could cough into their hand or touch their face and then touch the utensil, and then someone else could touch the utensil and touch their face.
Like
so yes, it is.
Yeah.
Exactly. So it is a potential. A good thing to do for these holiday events, and this is really great, I should have added it to my list, is to pre-plate or have someone do the serving and on the plates and then give the plate to the people instead of having people help themselves. In fact, people should not be going up to one central, even if you physically distance and have one person go up at a time, that's no good because then you're just exposing all the food. One person should be making a plate and giving it to everyone else. And to try to reduce exposure, or even better, making the plate, putting it on a table, then walking away, letting the other person come over and pick up the plate. The one other question sometimes at an event is about using bathrooms indoors. So now think of it this way. If someone is asymptomatic, it could be a super spreader event where they're asymptomatic. They are releasing a ton, they're just shedding a ton of virus, very contagious. And they might be in the hospital 3 days, a week from now, but at your event, they're asymptomatic, but contagious. If they go in and use your bathroom, those aerosols will just sit in the air indoors. Even if you turn on the fans and stuff indoors, it'll just circulate around your house, potentially for many hours. Even after the person leaves, their aerosols could still be circulating around your house. So it doesn't mean that you shouldn't let people come in and use your bathroom. I mean, you might want to consider not doing that. If you're in a high risk category, then maybe that's just off limits if they come over for an event. But if they do use your bathroom or they use it without you realizing it, one thing you might want to do is after the event is over, open all the windows of all of your house, blast the heat, blast the fans inside the house for a couple of hours before you go back inside of it. And then there will be plenty of air circulation inside with the windows open, all the fresh air coming in, that should probably be sufficient if there's sufficient air circulation for those couple of hours after the event is over, that will dramatically reduce any residual risk that's there.
Glenn, but if let's say you left the exhaust fan in that one bathroom and that's the designated bathroom and you keep the door closed, and if you're fortunate enough that you don't need to use that bathroom for a week or however you have another bathroom, how long would those aerosols possibly be in the air in the bathroom?
I don't know. The question is for you. It's not something that anyone has a clear answer to. Okay. I can guess based on how we know how long it stays in the air, based on what you're saying. The question for you is, if you had hindsight and you were to be able to see the future and know that a specific person was going to be in the hospital 3 days after your event and they were heavily contagious at your event, would you want that person walking around your house while they're contagious and in your bathroom?
I'd be buying a lottery ticket right now.
Well, that's.
Thank you, Glenn. That's very helpful.
Exhaust fan on and put a scotch tape over it so people who use it don't turn it off.
Oh, okay. Okay, we'll use the exhaust fan. Okay, thank you, Glenn. Thank you, Becky.
Thank you.
Oh, of course. There's all things we can do. We can't end our lives. So it's all about risk reduction. We have to choose how much risk we're comfortable with. If you're in a high risk category of severe disease, if you were to get infected, then your risk tolerance would probably be different. Or if you are a person who's maybe at low risk, but you live with other people who are at high risk, or you could have the potential to spread it, then that's a different type of risk category. And so we all need to be cognizant of ourselves and the people around us and adjust what risk level we're willing to accept based on that. Within reason. So like this idea of a person choosing not to wear masks because that's their risk level, no, that doesn't cut it in public. But what I'm talking about is some people might be more willing to let someone come in and use their bathroom, and someone might be less willing. If you decide you want to accept the risk, then there's things you can do to reduce it, such as opening the window, turning on the fans, these other things we've discussed.
Glenn, so much practical advice. And I don't know about you all, but did you know so much about cell function and how RNA and mRNA worked and all of these different transmitters before these conversations? I certainly did not. Glenn, I feel like now when I watch the news or I read different articles, I understand what's going on with these different vaccines. So you gave us so much practical advice in this discussion, not only about the holidays, but also really breaking everything down and really helping us to digest the different information that's coming our way these days. So we are eternally grateful. So we are just about at our time together. I wanted to give everybody a sense of the other questions that came in this week that we will get to next week. We're going to be talking about Typhoid Mary, who was an asymptomatic spreader of typhoid and how that could pertain to SARS-CoV-2. We'll, I'm sure, be talking more about holidays and the kind of travel that we then will have seen for Thanksgiving and what the landscape looks like because of that. We'll be talking more about evidence of heart infection and inflammation in healthy people infected with SARS-CoV-2. And we'll also be talking about long-term care facilities that were hit hard early on. And you'll be taking us kind of through what's going on in that population. So with that, it looks like
Rebecca,
you put a slide before we end.
Rebecca, yeah, one more thing. I just forgot this slide. So let me just spend one more minute on this. This is about the holidays in general. So for a lot of people, it is a very reasonable choice not to go to a holiday event, not to go to a big Thanksgiving event. However, so social distancing does not mean physical distancing. We should still all be getting together socially for these events, just not physically for many of us. So what does that mean? Consider hosting a Zoom Thanksgiving with an agreed upon menu, not just a Zoom meeting where you say, oh, hi, how are you doing? But literally have the same meal that you all cook independently. So you're all going through the appetizers at the same time and the meal at the same time. Let's get creative here. Maybe skip the bar. Some experts are saying skip the bar and get together with only a very few number of people. So if you had a larger holiday party previously, just only have like 2, 3, 4 people together this year. Try not to go cross country. So traveling makes a big difference. If you're going to travel, it's better to travel in your own vehicle, your own car, where there's less risk of interacting with other people versus the planes, where we have found super spreading events in multiple planes at this point. Cook dishes that remind you of home. So if you can't go home this year, cook dishes for Thanksgiving that remind you of home. Limit your in-person celebrations to just your household. No one from outside the household is an option. And if the weather holds up, if at all possible, even if it means wearing winter coats when you're outside for Thanksgiving, try to have the events outdoors. This makes such a huge difference with these pre-plated meals where people are not serving themselves. So Rebecca, with that, thank you so much, as always, Rebecca, for your help. It's always so much great. It's so great talking to everyone and with your help.
Thank you, Glenn, for all you do to prepare for these conversations. We all can tell you put a lot of thought and care into what you share with us. We're so appreciative. So everybody have a very, very happy and safe Thanksgiving and be well. We look forward to being together again next Sunday, same time, same place.
Thanks, everyone. Have a great Thanksgiving. Bye-bye.